Hello everyone. Today we are going to see about ERAS, which means Enhanced Recovery After Surgery. Now before I explain everything, let me just ask you this. Think about the old way of managing a patient after surgery. What used to happen? Patient was kept in bed for days, fasting for a long time, given heavy painkillers, told to rest completely. That was the traditional approach, but research proved that this was actually slowing down recovery and causing more complication. So a new smarter approach came, it called ERAS. I am Brenda Ronika, working as a tutor in Tribhulam College of Nursing. Objectives of today's section is define ERAS, describe its aims, explain the three phases of care, state the complications, discuss discharge criteria, and explain the nurse's role. Okay, first we'll move into definition. ERAS is a multimodal evidence-based perioperative care pathway designed to reduce surgical stress, maintain physiological function, and accelerate postoperative recovery. Okay, next we'll see the aims and objectives of ERAS. First, it reduces the physiological stress that surgery puts on the body. Think about it, surgery is a trauma and it stresses every system in the body. ERAS minimizes that stress. Second, it reduces how long the patient stays in hospital. Instead of 7 to 10 days, the patient goes home in 3 to 4 days. Third, it reduces post-operative complication. Fourth, it increases patient satisfaction because patients who recover faster and go home earlier are happier. Fifth, it reduces healthcare cost. And sixth, it helps the patient return to normal activity much faster. Okay, now we'll move into the important three phases of ERAS: preoperative, intraoperative, and postoperative. First one is a preoperative phase. Is all about preparation from the patient even enters the operation theatre. First is patient education. The patient is taught what to expect, what the recovery plan looks like, and what they personally need to do for self-care. An informed patient is a cooperative patient and that directly improves outcomes. Next is nutritional preparation. Before surgery, the patient is given protein loading to build up their nutritional reserves. If they are anemic, that should be corrected. If their BMI is very low, that should be addressed. The body needs to be in the best possible condition to handle surgery and heal afterwards. Then lifestyle changes. Stop smoking and alcohol at least 4 weeks or 6 weeks before surgery, because smoking impairs wound healing and increases infection risk. Alcohol also affects liver function and it increases the risk of clotting. Both must be stopped. Then medical optimizations, which means the patient, if they are having existing conditions like diabetes, hypertension, or cardiac problem, means it should be controlled before surgery. You cannot put a patient with uncontrolled diabetes through an operation and expect smooth recovery. Next one is a prehabilitation. It is a newer concept and very important. Before surgery, the patient does physical exercises, breathing exercises, and strength training. The idea is to make the body stronger going into the operation. A fit patient recovers much faster than a weak and deconditioned one. And the fasting guidelines are very different in ERAs from old approach. Solids are stopped 6 hours before, clear fluids are allowed up to 2 hours before, and a carbohydrate drink is given 2 to 3 hours before surgery. This reduces insulin resistance, keeps the patient energized, and reduces post-operative nausea. The old nothing by mouth from midnight rule is no longer recommended. ERAS changed that completely. Now we'll move into the intraoperative phase. It focuses mainly 4 key things. First one is a minimally invasive surgery. Wherever possible means laparoscopic or robotic surgery instead of large open cuts, because smaller cuts means less trauma, less pain, and fast recovery. Next is optimal anesthesia, which means regional anesthesia is preferred and opiates are kept minimal, because opioids slow down gut function and cause nausea, which delays recovery. Next, goal directed fluid therapy. which means giving exactly the right amount of fluid during surgery, not too much and not too little, because both cause problems. And next one is a temperature control, maintaining the patient normal body temperature throughout, because hypothermia increases infection risk and bleeding. So this is about the intraoperative phase. Next we'll move into the postoperative phase. This also has three main priorities. First one is a pain management. Using a multimodal approach, like paracetamol is given regularly as baseline, NSAID are added on top, and regional blocks given excellent pain control, and opioids are avoided as much as possible, because as I said, opioids slow the gut, cause nausea and delay recovery. Next one is the early mobilization. It's one of the most important parts of ERAS. On the day of surgery itself, the patient sits upright in bed and does breathing and food exercises. Day 1 they sit out of the bed and take short walks with assistant. Day 2 they walk in the corridor and increase distance, and day 3 they move independently. Why is this so important? Because lying in bed causes blood clots, chest infections, muscle weakness and pressure sores. Moving early prevents all of this. And the last one is early nutrition. Oral fluid starts within 4 to 6 hours after surgery. Soft diet by day 1. Protein target mainly should be targeted at 1.2 to 1.5 gram per day to support the wound healing and muscle recovery. So the old approach of keeping patient nil by mouth for days is gone. ERAS bring food back early because the gut needs stimulation to wake up and body needs nutrition to heal. Now we'll move into the very important part, discharge criteria. In ERAS, discharge is not based on how many days have passed. It is based on 8 specific criteria, and all of them must be met before the patient goes home. First, pain is controlled on oral medication with a score of 3 or less out of 10. Next, patient mobile and walking independently. And the next one is bowel function has returned to normal, meaning the patient has passed flatus or had a bowel movement, and patient is tolerating oral diet and fluids without nausea and vomiting. And the next is wound is clean, dry and shows no signs of infection. And the next one is patient is afebrile. Their temperature should be there in a normal limits, and follow-up appointment it should be arranged, and patient and care education it should be completed. As a nurse, you are the one assessing and documenting each of these criteria before discharge. If any single one is not met, the patient is not ready to go home, you have the responsibility to escalate that to the medical team. Okay, even with perfect ERAS care, complication can still occur. You must know them and watch for them actively. First one is the post-operative nausea and vomiting is very common, so monitor and give antiemetics as prescribed. And post-operative ileus, like gut goes down and not waking up. So signs are no bowel sounds, no flatus and abdominal distension and inability to tolerate feeds. So if you are seeing this means you have to immediately report it. Next one is a wound infection, like you wound it will look redness, warmth and swelling, and discharge it will be there, and patient will have fever also. So catch it up earlier. And next one is a VTE and DVT. So blood clot in deep veins. So it should be prevented by early mobilization using compression stockings and using anticoagulants. So as a nurse we have to monitor for leg pain and swelling. And the next one is a urinary retention. So as a nurse we have to monitor urine output every hours, and if it is decreases means report to the physician immediately. And at least every 1 hour we have to monitor temperature, because there is a risk for hypothermia also. So all of these are manageable if you catch up them early. Now let us talk about our role. In ERAS, the nurse is not just following orders. The nurse is a central and active participant. So we have 6 roles. First one is a assessor. We have to do the preoperative baseline covering fitness, nutrition and psychology. And the second role is educator. We have to teach the patient about ERAS pathway, what to expect and how to care for themselves at home. And the next role is caregiver. So we have to execute the ERAS care plan at every single phase from pre-op to discharge. And next role is coordinator. So we have to liaise between the surgeon, anesthetist, physiotherapist and dietitian. So ERS is a team effort and the nurse is the thread that connects the team. And next, monitor. So we have to monitor the baseline, every vitals and everything. And next one is the advocate role. So we have to speak up for the patient and ensure ERAS protocols are being followed correctly at all times. Without the nurse, ERAS is just a document. So we are the one who brings it to life at the bedside every single day. Thank you.